The periocardial connection, what is the link? The link is, quite frankly, an inflammatory response. And the inflammatory disease is pervasive around the body. The link is very specifically the link of inflammation. It is that inflammatory response. Now, indeed, you mentioned CRPHS. We look at CRPHS, but we're also looking at plaque-2. And what you'll find about plaque-2 is really quite fascinating. It is actually a participant in the inflammatory response, in the vascular inflammatory response. And what's interesting about that is that the blood vessel, which would at one point appear stable, that plaque, of course, that ruptures is the God forbid that happens. And when that happens, that's when everything goes to hell in a handbag, if you will. It is the unstable plaque that we want to minimize. If plaque-2 is a participant, and if plaque-2 actually, we think that it actually links up with the LDL molecule, helps it to oxidize, gets the LDL molecule inside that vascular wall, and then poof, you have a problem. If we can minimize the plaque-2 coming from other inflammatory processes, then we think that we can actually limit the disease. You know, the old story about heart attack and stroke was that that blood vessel just eventually came together and all of a sudden, poof, you had a heart attack. But that's not really what happens at all. And I'll show you that during the course of these slides. It's really the ruptured plaque that you have to be afraid of. That's the guy that's out on the golf course and he's swinging his golf club and he drops to the ground, he's had a heart attack and he dies. That's the thing you want to prevent. The person who has angina that starts to have a little bit of chest pain, more and more and more chest pain, that's the blood vessel that's compromised. That you have a chance to correct. You don't want it, but at least you have a chance to correct it, stent it or bypass it. But the guy out on the golf course, it's a done deal once he falls over or has a stroke or has a heart attack. And that's what the plaque-2. The plaque-2 tells us that there's an unstable plaque and there's unstable active inflammation going on in that plaque. In fact, the study that was done was actually done in Seattle, Washington. And I spoke with a cardiologist who a pathologist was really kind of interested in this. And so he called the cardiologist and the pathologist were there together one night at 2 o'clock in the morning with the patient. And they actually extracted this clot and the pathologist was there to actually look at it under the microscope because no one knew this at that time. At this time, you know, less than 10 years ago, we still thought that it was, you know, that blood vessel getting smaller and smaller and smaller, or as you said, maybe a piece of something kind of coming off and going downstream and causing a clot. What you're referring to is an embolic phenomenon. So for instance, when a person has some schmutz inside their heart, that schmutz can actually come off, go through the valve and go up into the brain and that's an embolic clot. It's a reason for a stroke by all means, but it is not the primary reason. Thrombotic stroke is by far and away 85%. A lot of people go to the emergency room, they have chest pain. They leave because their hormones, their enzymes are negative. They're not having any at that time muscular breakdown. The heart muscle is still intact. So they're sent home. A huge number of them have a heart attack within 6 months. We think it's the inflammation. Maybe just what you were saying, that a little bit of rupture of that inflammation that makes them have some chest pain, but indeed does not damage the muscle enough that we see a release of enzymes, muscle enzymes, that we can detect it. In any event, this is the stuff that you guys know a lot better than me, but I started to learn about it. So we know that the acid is what causes havoc in the mouth. We know that a lot of people have acid reflux. The xylitol opportunity to maintain a good dental health is something that I came across, and I'd be very interested in any feedback. I can show you where I did all the reading and why that might be preventive in addition to all the other things that you do, the scaling of the teeth, et cetera, et cetera, et cetera. The DNA testing was new to me, and it may be new to you, but they actually can now test for the bacteria that most commonly theoretically cause plaque that is associated with heart disease, and they actually can do DNA testing to see if you have that kind of stuff in your mouth. So they can culture and do DNA testing. So there's a whole laboratory that does it. And interestingly enough, I cannot do it. This company will not let me do any of this testing. They will only let dentists do the testing.
There's actually a couple tests. The one that you can actually take direct cultures, send out, and they'll give you a panel and tell you what antibiotics that they would recommend. Some of my periodontists, they don't deal with that. They kind of treat it, but they know what the traditional ones are, and they're going to hit it with metronidazole and like Augmentin. They just combine the two.
They combine the two.
And they hit them with that. There is a DNA test that you can do for patients to see if they are more prone to periodontal disease, but from a standpoint of the cost, which is a few $100, if they've got it, they've got it. I mean, so what's the point of testing them?
Sure, sure. That's a very good point.
So that's where
and I find that in my practice, it's patient dependent. So there are some people who don't want to do that, and there's some that, it's kind of like you get the look from the patient as to how they want to approach it, and I try to do whatever I can to help them hear me, and so I have to know what they'll listen to. And so indeed, sometimes some people need just an excuse to be able to take care of themselves. You're absolutely right, without the guilt. There's no question about it. Patients are humans just like us.
Gotten fairly big in dentistry is the referring to biofilms now, and how that is
I have
really
that as
dealing
part of my
with
talk. That was fascinating to me. It was fascinating to me. I actually sat and listened on my computer to a guy lecture for 45 minutes on biofilms, good, bad, and ugly. A lot of stuff I didn't know. Great. So I don't know if this actually has any value, but indeed, the what to eat and what not to eat. But certainly there are studies about people who eat a lot of acidy foods and who perpetuate their, if you will, bad bacteria. And then, of course, what to eat. Of course, on the other side of things, we don't tell people to eat. A little chocolate is good, dark chocolate. Potatoes is not something we generally advocate. But what I thought was interesting was pineapple maybe over a lemon, and certainly artificial sweeteners and diet sodas are probably the bane of your existence, and they don't serve us very well either. So I try to get patients to take water. Duh, it's a lot less expensive. Go ahead, next please. So this was the inflammation that we were talking about, the causes of inflammation, how we monitor it, and how do we prevent it. And I'm going to go through a few slides to explain this to you. And maybe this will clear up some of those ideas. Go ahead, Corey, next slide. So this is the slide that I use a lot, because in life, it's always us versus them. And I have a little philosophy, and you certainly are you don't have to agree with me, but genetically, we're all already predisposed to die, actually. We're supposed to make babies, and our genetics is supposed to be propagated, and so everything is supposed to be about reproducing, right? Because the genes want to maintain themselves, and they want to reproduce. So theoretically, as a woman beyond menopause, I'm just eating the food of the young, and I should be gone already. I've decided that maybe life is worth a little more than that. But indeed, if that's the case, if I want my body to last longer than its prescribed genetic predetermined length of time, then I need to do something about it. So it's kind of like if you buy a car, it has an expected lifespan. It doesn't go on forever. You can take very good care of it, but you got to know what's going to go bad and what pipes need to be redone. And so basically we kind of just believe in, where does the house need to be repainted? What do we need to do to maintain it? And how do we maintain a life expectancy of 90 years, which is what our patients expect now, when genetics will tell us that things start to wear out at the age of 50 and 60. In fact, Karen will tell you that if we test for beta cell dysfunction and diabetes, almost everybody over the age of 60 has beta cell dysfunction. They're going to get diabetic in 20 years. And all through time, it's always been us versus them. So I talk about caveman versus the bear, and the bear usually won. And then, of course, we had sanitation that really dramatically improved our length of life, and you know what that was all about. Of course, cancer and immunosuppression, that's all a case of us versus them in the immunologic system. Certainly infection, autoimmune disease, and vascular inflammation. It's always our ability to fight off inflammation, or somebody or something, if it comes from the outside or the inside, but it's always us versus them. So it's a question of trying to minimize inflammation and minimize the bad stuff as much as you can. And then how do you measure that bad stuff? How do you know what to look for? Am I going to die of a stroke or a heart attack? Or am I going to get pancreatitis? Or am I going to have, what is my potential disease? That's where the genetics comes in. It's not 100% right, but if you have a probability of having a heart attack because your dad died at 50 and your mother died at 40, and you've got the gene, well then you better really hone your treatment and hone your eye on heart disease and stroke, because that's likely to happen. It may not, but certainly 1 + 1 = 2. If your whole family has cancer, then that may be where you want to look for things. But in any event, people generally, and I say this with caution, but people don't necessarily live to 90 without actually some intervention. bones get bad, all those kinds of things just happen. It's an aging phenomenon. Osteoporosis is not a disease, it's just an aging phenomenon. I'm all about prevention and extending the prime of a person. Living well for as long as you can. So whatever we need to do to defeat them, whatever them is, that's what we're trying to do. Go ahead, next slide. So this is the inflammatory process, and this is probably just a glimpse, but it's very, very, very complex. And as you can see, there's platelet activation, which we talked about a little bit, thrombosis, which is, of course, clot formation. PGs and leukotrienes are pro-inflammatories. The nitric oxide is what I was talking about in the endothelial cell inside the blood vessel wall that is so important to maintaining a good, strong blood vessel wall and a barrier between what's inside the blood vessel wall and what's traveling through the vascular system. There's vascular proliferation, which we talked about a little bit, recruitment of inflammatory cells, and you can see that you get all kinds of inflammatory states. This lists CRPHS as that one marker that you can measure, but plaque-2 seems to be the specific vascular marker. The question of whether CRPHS is specific for vascular disease comes up all the time. There are my colleagues who say CRPHS is specific. It is not. It is just not. It is elevated in people who have collagen vascular disease. It can be elevated in somebody who has a bad cold. It is almost always elevated in somebody who's fat. And I think that it is actually perpetuated by visceral fat and the pro-inflammatory enzymes that come off of visceral fat. We're in the process of looking at that in the leukotrienes, and I know that IL-1 and IL-6 I think are very prominent in your literature, but we don't measure those on a commercial level yet. But that soon will be coming, and I'm guessing will be another place where we'll focus on those inflammatory factors that we can monitor, hopefully make better, and then diminish the likelihood of disease. This was a very important trial in healthcare, and this says a lot. So patients with a normal LDL, which we used to think was about 130, years ago we said a normal LDL, that's the bad cholesterol, was less than 160. Then we recognized that as many people had a heart attack with an LDL of over 160 as under 160. Oops, we better find a better model. So we started looking at less than 130. We're now down to looking actually at an LDL cholesterol of as low as 60 as being where the mark is. And it's very interesting how we got there. When you look at other mammals outside of us, outside of humans, who don't have heart attacks, their LDL is 50 to 60. So we're actually starting to look at getting the bad guy down to really, really low levels. The data is not out there yet, but we do know that there are some studies that show that when you get that cholesterol down, that bad cholesterol down to that low, you really can minimize heart attack and stroke. That said, this study was done with people with theoretically normal LDLs. But they had an abnormal CRPHS, which was greater than 2. The mean CRPHS in this study was 4.2. They were treated with Crestor. The trial was stopped after 1.9 years. The cholesterol levels were indeed reduced by 50%. The mean cholesterol was 55 at 1 year. CRP levels were reduced by 37%, and the mean was at 2.2. The treated event rate was 0.77 per 100 years versus 1.36 per 100 years in those not treated. Very substantial. And actually, as they're looking at these statin drugs, and you know them as Crestor and Lipitor and Provocol and Simvastatin and Zocor, you know all those drugs. What we're looking at is actually they may be as much an anti-inflammatory as they are a reducer of LDL. So their anti-inflammatory capacity may be as important or more important than even their capacity to decrease LDL. But in any event, this showed that by basically closing down the inflammatory process, you could actually prevent disease. It wasn't just the LDL. Many of these people would never have been treated because their LDL was theoretically normal. Next slide, please. So what this means is no other risk other than elevated CRPHS, at least no other risk that they knew of at the time. Those with the only inflammation have an increased risk of heart disease and stroke, and the specific inflammation is less important than the fact that it exists. So that's where you and I, where the rubber meets the road. If they have inflammation in your office, then I should be concerned that they're going to have a heart attack or stroke. And so that periodontal inflammation, that periodontitis, can be just as important as any of these other inflammatory processes in being a predictor. And as I said, there are some studies that are showing between 17 and 25%. So what to test? These are the pathogens that you guys know of, and I am not even going to begin to pronounce them because I couldn't pronounce them. And the genetics that we look at. Basically, what we're looking at is an overproduction of interleukin-1 and a cytokine that amplifies inflammation. So theoretically, these are the bad guys, the gram-negatives that create all of that bad stuff that you guys know all about, that potentially creates an inflammatory process that could be responsible for inflammation elsewhere and heart attack or stroke. So why is it important? Well, there's no question that coronary artery disease decreases life expectancy. There's just no question. And this is just one of those studies that everybody uses. There are 3 studies that showed, and they all show basically the same thing. The relative risk of disease goes up as the total cholesterol goes up. So there's no question that cholesterol is important and we need to monitor it. Next slide. In our business, this is where the rubber really does meet the road. So people either eat cholesterol or they make their own cholesterol. The liver is the primary organ where all the action takes place. And the first cholesterol to come off of the liver is actually VLDL. That represents very low density lipoprotein. It's a big fat molecule. It holds mostly triglycerides and a little bit of cholesterol. All of the bad guys, VLDL, IDL, LDL, LP(a), all of the bad guys have a specific protein on top of them called ApoB. And I'm going to show you why that actually may be a very good measurement of how much of this bad guy stuff is running around. These molecules actually exchange cholesterol and triglycerides among themselves as they travel through the bloodstream. They are carrier molecules. They're like suitcases. You know, fat and water don't mix, and cholesterol and fats are fat. So you can't put them into the bloodstream and expect them to get anywhere. They would clog up the system immediately. So we put them in a suitcase. And the suitcase is what we call a lipoprotein. And that lipoprotein can travel through the system because basically the receptors facing outward are hydrophilic and those looking inside are lipophilic. So all of the fats are on the inside and all the water-based stuff is on the outside, and they travel, and they literally are carrier systems. They take cholesterol and fats throughout the body. That's all they do. Now, why is LDL so important? Probably because it's the smaller molecule. By the time it gets to LDL, most of the triglycerides have been distributed and you're left with just cholesterol. LDL has a half-life of 4 days. These other molecules have half-lives of hours. So now you have a molecule that sticks around for a long time, is pretty much cholesterol, has the majority of that leftover cholesterol. So it tends to be the culprit, although in my business we measure them all, because they all can be important, and again, depending upon the genetics of the person, one can be more or less important than the other. The enterocoel represents the intestine and how the chylomicron, which is that big fat thing you read about, I know you guys learned all this, that came out of the intestine and went to the liver. And LDL can be exchanged at the liver. HDL, of course, is the good guy. HDL is the representation of, I call it the trash truck, the guy that comes by and picks up all of the trash. The bigger the molecule, the better. Theoretically, the smaller molecules are more easily oxidized and can get into the blood vessel wall and cause havoc more commonly than smaller molecules. And everybody has their own distribution of size of molecules. It's genetic. If you make small molecules or subtype B, and 80% of heart attacks take place in subtype B patients. So if you've got small molecules, you can make them bigger. Niacin is the only drug that does that, quite frankly. So you can change that whole lipid profile with medications. Unfortunately, good diet and good dentistry don't get that part done. But niacin has been proven to be very important in our armamentarium. So again, these are a lot of the same picture, a lot of pictures just to elucidate the same pathophysiology. We actually do measure the LDL to HDL ratio. It is more important probably than either of them alone because, again, bad guy, good guy, what's the ratio? So we measure that, and this gives you some idea of how the lipids are on the inside and the outside is the water-based part of the particle. Next slide, please. This is what I was talking about. We don't even measure the right things, perhaps. I mean, that's what's so fascinating. So we measure LDL. But maybe we should not be measuring LDL and how much cholesterol is in each of those molecules, but maybe we need to be measuring how many molecules, how many total number of molecules. And so what they did here was they talked about LDL particle number varied between those with low LDL-C and high LDL-C. So as you see on the top slide, what you'll see is that the LDL-C is between 70 and 99, very low. An LDL of 77 to 99, pretty good. And as you can see, there are people who have a fairly high percentage of having a heart attack that have an enormous number of particles, of total number of particles, that has no bearing on, I mean, there's no correlation between the amount of LDL and the number of particles. Even when LDL is less than 70, there are some people who have very, very, very many particles hanging around. So is it important to get the LDL down to below 70? Is it more important to measure the particle number, which we can do? There's some labs that do that through the Cleveland Clinic. And the conduit for that is ApoB, as you'll see in the next slide, because that ApoB protein is the protein that actually sits on top of that molecule. So this is another study showing that the LDL particle number could be a better indicator of risk than just the amount of LDL-C. So as you can see here, this is a high number of particles and a low LDL, and look at the mortality. Here, these people have low LDL and high LDL-C. This is low particle numbers, but high LDL. But their particle number is low. They don't have heart attacks. These people have high LDL-C, but they have low particle numbers. So it's particle number that seems to maybe be the more important. How many of those particles are actually carrying the yucky cholesterol around, not just the LDL? So of course it always comes as a slap in the face when you go, oh, I've been measuring the wrong thing for how many years now? But indeed, the debate goes on, and you could talk to the Cleveland Clinic and you could talk to Berkeley Heart Labs. Everybody has their own opinion. The studies are not definitive yet. But I think it's just something that we have to consider if we're going to predict who's going to have a heart attack and stroke, we ought to be measuring the right thing. And this is a slide showing that ApoB, that protein which we can measure, and that's easily measurable at any of the local labs, you can actually measure, and you can see the low ApoB people have a much greater survival probability than the high ApoB people. So if you've got too many particles, you have a lower survival opportunity than if you don't have as many particles. Do you see that? I mean, this is a very significant differential, and the p-value is very, very low. So it's very statistically significant. So again, perhaps we've been measuring the wrong thing, and we shouldn't be asking patients, what's your cholesterol? We should be asking them, what's your ApoB? Go ahead. So this is the process of atherosclerosis, and this is precisely what I was talking to you about. So normal arteries, you can see, nice and round. But look at, if you were just doing a cardiac cath, and you looked at this vessel versus this vessel, you would not see that there was any distinction. Because the cardiac cath only looks at flow. So you see normal flow. We do have opportunities to look at endovascular ultrasounds, which is probably ultimately the best way to do it, but obviously it's invasive. I'm going to show you what an ultrasound and an external ultrasound can do. But probably the best method is an endovascular ultrasound, where you actually put a catheter into the artery and you have an ultrasound on the end, and you can actually look at that wall. Because if that wall is thick, that's a plaque, but you're not going to see it on a cath. That person will leave that cath lab and be told that they are entirely normal, and they are absolutely at risk. This is a slide showing the endothelium. Now, the endothelium it's the barrier, and these cells actually, they interdigitate, and they are the barrier. If your endothelium is strong, the bad stuff doesn't get inside, generally speaking. We also can measure how strong that endothelium is. There are endothelial function tests and endothelial dysfunction tests, which actually measures the arterial response to, they pump up your artery, they pump up your arm like you're going to do a blood pressure, causing vasoconstriction. Immediately the blood vessel gets crazy, something's going on. We then take down the blood pressure cuff, and we can actually measure the amount of nitrous oxide and vasodilatation in the distal part of the artery. And this is of course all third hand, it's not direct, but we think that it is a measure of how much good nitrous oxide is in that blood vessel and the normal response. That's one way of doing it. The other way of doing it is we test the amount of protein in the urine. This endothelium is the same endothelium that protects the filtering system in the kidney and keeps the proteins inside and lets the urea and all the other products of waste go out. If you're losing a lot of protein in your urine, that endothelium is not secure. So if you want to look at kidney disease, you look at what they call an MACR, a microalbumin to creatinine ratio. That ratio greater than 30 means you got kidney disease, but a ratio greater than 4 in a male and 7.5 in a female means you still have a leaky endothelium. That doesn't mean that you've got disease, but it certainly means that things need to be closed up and you need to take care of that endothelium. What causes a leaky endothelium? Hypertension, smoking, diabetes. That's why diabetics have such horrible kidneys. You can actually predict their kidney disease based on how much protein they're losing. And you can predict it years in advance if you monitor it. Next, please. And again, we talk about with the injury to the endothelium, hypertension can cause an injury from stress. That endothelium becomes more permeable. The nitrous oxide production goes down. White cells are migrated in the vascular growth stimulation, which actually comes from down under, up in. It comes from the smooth muscle layer. And all of that forms this fibrous inflammatory process. If it's stable, it'll calcify. If it's not stable, it has the potential to rupture. That's the person that dies on the golf course.
So the inflammation in the muscle tissue.
And the intima, this is called the intima,
But the inflammation then attracts or brings in the cholesterol molecules, which is really designed the body's way to try to repair what is.
But it doesn't repair. Exactly. The cholesterol molecule comes in, it's swallowed by a macrophage,
Sits there
and the body says, foreign body, and I'm going to attack it. Exactly. So cholesterol has, as you know, very useful purposes. Cell wall structure, hormone creation. You know, we all need cholesterol. Good hair, right? Sex hormones, hello. But when it's delivered to the vascular wall, the inside of the vasculature, it is a foreign body and it creates an inflammatory process. So again, this is the stable versus the unstable plaque. So it's that thin, fibrous plaque that has the opportunity to rupture. And indeed, sometimes there's a very thick fibrous plaque, as in this side. This plaque is actually stable. It will eventually calcify and go away. Go away in the sense that it's not active anymore. You may see it on a calcium or coronary artery test, but it's not prone to cause a problem. Indeed, if it gets bigger and bigger, and if it starts to grow inward, it can obstruct flow. That person might have angina. But angina and a heart attack are two different things. Angina means there is not enough flow to get to the heart wall, to the heart muscle. And you can improve that obviously with stents or bypass. Heart attack means you have completely clogged up the blood vessel. It's kind of like if you're on a highway, an 8-lane highway, and if they give you plenty of warning that there's a detour, you got plenty of time to get where you need to go. You can call ahead, I'm going to be a little late. You slow down, but you can still get through slowly but surely. That's the clot. It's that immediate fibrous plaque that is unstable, that ruptures, that causes heart attacks and strokes. And it is the same process anywhere and everywhere, including your peripheral vasculature as well, legs, everywhere. People could have obstruction in the renal arteries, anywhere. And this is my oy vey slide, because there's just so much. There are so many places, as you can see, where we might intervene. So many places. Where do you start? What drug is more important? What do you monitor? That's why we're not as good at what we do as we think we are, or as we need to be. So you've got all these kinds of things. You've got diabetes, insulin sensitivity or not, a metabolic syndrome, which is part of the same thing. You've got cholesterol issues. You've got blood pressure issues. I mean, goodness gracious. And that added to stress and all the other inflammatory processes, all those things are risk factors. It's almost too much to manage. What do you manage? Well, I think that you look at the simple things, and teeth are simple. They may not be, they're relatively simple. It's something that you can deal with. Some of these things we can't even measure. But teeth and dental disease and poor dental hygiene, we can see it, and to ignore it, nuts. But, doctors are nuts sometimes. Go ahead, next slide. So this is another way of looking at the risk factors. Believe it or not, migraine, particularly in males, is a very strong risk factor. Abnormal lipids, obviously, hypertension, migraine in men. Collagen vascular disease, in fact, it is huge, the number of patients with heart attacks that have untreated collagen vascular disease. I have not yet seen the study, but I have talked to my friends who take care of these patients, and I am positive that the new biologics that we use, the Remicades and the Humiras, my patients don't get heart attacks because they shut down tumor necrosis factor, and they probably shut down inflammation enough. They really decrease the risk of heart attack and stroke. But if you don't treat these people, they have constant inflammation. And usually what we do is we give them a little anti-inflammatory, which does not shut off this inflammation. And they are at huge risk, huge risk. Next, please. Other risk factors including stress, elevated heart rate, elevated uric acid, diabetes, PCOS is what I mentioned, smoking, restless leg syndrome, erectile dysfunction. Hello, you name it, there's a risk. Living is a risk. But in part of this, it's because, as I said, genetically, these are the things that break down as we get older. our body and all those things that, you know, we make and we are, is all prone to reproduction. And at menopause, my estrogen goes away. I become very unruly, unless I take my estrogen. I don't sleep well, sleep apnea, or other. My estrogen is gone. And in fact, you know, we had in medicine, we had the Women's Health Initiative. You may remember that study with, you know, where women who were at the age of 65 were started on estrogen and progesterone. Of course, none of us do that. We don't take a 65-year-old who's feeling healthy and give them estrogen and progesterone. Nonetheless, that very poorly articulated study was done, leaving us with a very poorly designed study, a horrible result, and never the opportunity to look at estrogen and its ability to protect us from heart disease. I know that there is a subset of women who are very protected by estrogen, and it only makes sense. You don't see women premenopausally who have heart attacks. 25% increased risk of cardiovascular disease, if it's a coronary artery disease, if it's present. You're 3.8 times more likely to have a heart attack if present, 2 times more likely to have a stroke. And your CIMT, which is your carotid intimal thickness, I'm going to show you what that is increased. So you guys have to help me, because you are as much a reason for, your patients with periodontal disease are as much a reason for heart attack and stroke as any of the things that I have. And I'm not smart enough to know who has disease and who doesn't. I can look in their mouth, and we do, but that's beyond my expertise. I'm not going to be anybody to say, you know, I can say your teeth look really awful, you need to see your dentist, and I ask them, do you see your dentist? Everybody lies, they say, of course, right? But they need to see a dentist. I mean, you guys will help me save their lives. I don't mean to call you guys, you professional dentists will help me save their lives, and I need you. Next, please. This is where it kind of gets interesting. This is the PLAQ2. PLAQ2 is one of those enzymes that I was talking about. It's not CRP, but it is an enzyme that is directly involved in that vascular inflammation. We think that it is very important in periodontal disease. We think that it actually hooks up with LDL, helps it to oxidize, and then participates in the vascular reaction itself. I know that having an elevated PLAQ2, they're at risk for a ruptured plaque, for a plaque that could be a problem. And so when they have that, I will call you and say, please help me. Do they have periodontal disease? If they don't, fine, then I have to go back to work. But there's a known association, and I will be happy to share any of our literature. And maybe one of these days we'll do our studies, because we need to start doing studies on this stuff. 37% of those people with no other risks had elevated PLAQ2. So you can see the level of my frustration, because there I am, I've got everything under control. Blood pressure is good, everybody's happy, everything is looking good, uric acid, everything, you know, and their PLAQ2 is elevated. So this is the CIMT that I was talking to you about. This is different than having a carotid ultrasound. When they go for a carotid ultrasound, I hear a bruit, which means, of course, increased flow. So I am suspecting that there is some obstruction. That's way beyond this process. So they already have so much going on that they actually have obstructed their carotid arteries. Some of those people actually go on to have surgery. As you know, they have carotid surgery, and they get unobstructed, if you will. But far before that, we can actually now, using a different kind of probe on the ultrasound, we measure the blood vessel wall. So this stripe here is the intima. This very dense stripe right here, that's the intima. And if any of you want to have your carotid intimal thickness done, I will do it for you. I have the probe here in my office. That is inflammatory disease. It's not a plaque, it's not calcium, it's heterogeneous inflammatory disease. That person is at risk of rupture. That's me. Now the next question, which we can't answer because I don't know the answer, nobody does, is after I treat myself, after I do everything that I possibly can, when does that get better? How long does it take? Nobody knows. I can tell you, one day it does. One day is too long. I've been treating myself for close to 6 months, and I don't see an appreciable change yet, which makes me very, very nervous. And my numbers are great. My LDL is 37, my HDL is 60-something. You know, I've lost weight. You don't know this, but I used to be much heavier. You know, I really have done all the right things, I think, but I still have plaque. Do you remember when they were doing all the drug studies on Zetia? and they basically, the drug studies were stopped and they said Zetia doesn't work. The reason that that study was so poor is that they were measuring carotid intimal thickness, and they were measuring over a period of time whether it changed, and it didn't. But what they forgot to measure is whether that was important in terms of their disease. Was it getting better, but it just hadn't changed on the scan? How long did it take? They asked the wrong question. This is important as a predictor. For me, if I have a patient who says, I'm not interested in taking your medicine, Dr. Zwelling, I don't have any family history, I don't have a problem, I show them this, they get serious. I got very serious. So I use things like this. Obviously, if their cholesterol, if their LDL cholesterol is 200 and their HDL is 25, hopefully I've convinced them to start to treat themselves. Clearly, if they already have calcium and a coronary calcium score, I know that they've had disease. But sometimes, as I said, that calcium score is 0. And this is a 60-year-old person who may not have that heart attack for 10 years, but I'm really not interested in waiting for it. So if I can see a predictor and I can stop the process, or what I say is make that artery go cold. Just make it cold, make it not active, make that wall stable. I think that's my job. The problem that I have and the problem in the literature is how do we know that we've absolutely done that beyond a doubt? And I don't know that answer. I can get all the numbers looking good, but I'm still not convinced that that's the best way. I look at all of it, but the experts in the country don't have, they can tell me that it's a pretty good predictor, but no one can tell me 100% of the time. And the person that's sitting, in my office, they want to know they're safe. So this is the soft plaque. They did a study with 250 stable patients. 112 of them had that, what we call that echolucent or soft plaque, and 29 of them had coronary events. 103 without soft plaque had coronary events. 11 CVAs in the group with soft plaque. This is really interesting, and this shows you how not so good we are. I'm an old person. So when I came into medicine, we measured CKMB. Karen's old enough, she remembers that. Yeah, exactly. So what we were looking at is CPK was a muscle enzyme specific to liver, heart, and brain. Not very specific. But we thought that if it went up and we could measure the cardiac component, that obviously if it was high, there was damage to the muscle. Therefore, that person had a heart attack. So we would measure CK levels. Well, you can see in a time frame how long that might take to go up. So are you going to send the patient home who comes in at this level? Well, you surely might, because that level would be normal. So we said, we got to do a better job. We got to have something that's a little more specific. And so we started to measure troponin. And troponin levels are a little more specific, although you can see the time frame is still not very good. Why? Because it measures muscle. It's a muscle enzyme. So the muscle has to die before the enzyme is exposed to the blood vessel and you can measure it. If the muscle isn't dead, you don't measure it. So if the person has not had an event, if you will, or if their event has not caused muscle damage, then you don't measure it. Those patients go home. But you can see that there are things that we can actually measure better. Myoglobin is not specific enough, even though it goes up sooner. But look at this enzyme called myeloperoxidase. And myeloperoxidase turns out to be a key. It also is the enzyme that scares the heebie-jeebies out of you. So if you have that enzyme that's elevated, you can almost be sure that that person is ready for an event. So now you have that 80-year-old who has a risk of heart disease. They go to the hospital, they have chest pain. Okay, their enzymes are normal. They go home. They are at risk. And if their myeloperoxidase level is high, you got to go and find out what that risk is and what you need to treat. I've had several patients, Joni will tell you, I get the heebie-jeebies when the myeloperoxidase is high. I have found it in one patient post-operatively that their level was high. And of course, that makes it, in fact, I spoke with a guy by the name of Mark Penn, who is the leading author at the Cleveland Clinic of all of this research. And I told him that one of my post-op patients had an elevated level, and that was very bothersome to me because post-op, a lot of people have risk of heart attack and stroke, right, within 6 months of a heart attack. And I was bothered by the fact that that myeloperoxidase was elevated, but the patient I thought was stable because it came right back down. So perhaps what the patient is feeling is, there's all kinds of reasons for pain. And the prostaglandins are a very common component of vascular types of pain when they're released. So obviously some enzyme gets released, the patient has pain, They go to the hospital, but they have not had any muscle cell death. But they do have an enzyme that is perpetuating their vascular problem, and you really are compelled to find out what it is. So we check myeloperoxidase levels in all my patients that have chest pain. We think we're so smart in capturing this disease, and we miss a lot because there are a lot of people who still have heart attacks and strokes. Next, please. So plaque-2. Plaque-2 predicts short-term risk of stroke patients with TIA. It's a player, not just a marker. CRPHS we think is a marker, not so much a player, although there is some dispute about that. But you can actually measure, as I said, the plaque-2 inside that vulnerable plaque. It's vascular-specific enzyme, inflammatory enzyme that does not seem to be as affected by other systemic infections. So persons who have colds or flus do not have elevated plaque-2s. It's an independent risk factor, including obesity, and patients with periodontal disease were 1.8 times more likely to have plaque-2 in the highest quartile. So the question is that inflammation perpetuating the plaque-2? And then does the plaque-2, is it a causal factor itself? A causal factor, not just a player, but it actually, when it hooks onto that LDL and oxidizes it, it actually perpetuates an unstable plaque. And that's why I need your help. Because this evidence tells me that it might be. I can't be sure, but it surely might be. And it would be very prudent to make sure that that person is not in an unstable situation. It's not significant after adjustment for age, gender, smoking, waist circumference, or BMI. But among individuals without any other cardiovascular risk factors, 24% had a history of periodontal disease. And as I said, 37% had elevated HS, CRPHS, or plaque-2. I mean, we all know that lower economic people have a greater disease. Is that because they're inherently sicker? No, probably because they don't eat as well and they don't have the opportunity to access health care as much. I don't think they're born sicker, but I do think that, so all those things are associated risk factors. Next, please. This is the atherosclerotic risk in community studies, otherwise known as the ARIC study. And the ARIC study, as you can see, showed that as the high LP little, the plaque-2 level, as the plaque-2 levels go up, the risk ratio goes up just substantially. It's pretty impressive, I think. These are people with low plaque-2 levels. Next, please. This is the meta-analysis that I found that was done all the way back in 2002. Periodontal disease in this study was associated with a 19% increased risk of cardiovascular disease, and it was most prominent in those people less than 65. And this is, of course, becomes huge as a public health issue. And at least the data that I read showed that up to 40% of people have periodontal disease. Is that your thinking? And those are probably the patients who come to your office, little than the patients who, treat their cats better than they treat themselves. Next, please. This was a study in the British Medical Journal done by a gentleman by the name of De Stefano. It was a study done all the way back in 1993 with a cohort of 9,760 subjects, 25% increase in the risk of coronary artery disease with those with periodontal disease, but no evidence to indicate that antibiotics should necessarily be recommended, and there is no study that shows us that that will help. That's the frustration. So you find the disease, you treat it, like you said, if you've got it, you treat it. Why don't we find an associated decrease in risk just by the treatment of antibiotics? I don't know. So that leaves us with the next thing. What do we do when we find it? How do we treat it? Obviously, I will count on you to treat the periodontal disease. How in the variety of ways that you do it, with taking it off literally, manually, giving them better diets, giving them good advice on dental hygiene, giving them whatever antibiotics, and then I keep measuring their plaque-2 levels and hopefully, or whatever other risk factors they have, and hopefully they go down. But there are no studies. As I said, maybe this is a study that we should start to do together, because I think that we might be able to actually save lives. The recommendations that are those with periodontal disease should be evaluated with any variety of things. We talked about the CIMT, the coronary calcium score, inflammatory markers, and lipids. Obviously, we treat the periodontitis, and we minimize other risks, like we tell patients to quit smoking and lose weight and all those other things that nobody listens to. Next, please. We try. This is that lab that I was telling you about. Is this the one that you're aware of? So this is the lab. They're called they're oral DNA labs, and in fact, I would love to know what you think about it. And she said, if it's not necessary and a patient doesn't have to spend $200, and indeed, if they've got it, right? And I think we should be aggressively treating it. And you let me know that there's a problem, and I'll monitor my end. And if I have a patient that tells me that they don't go to the dentist, I'll follow up and make sure that they do, and actually call your office and make them the appointment. But I think it's just really important that we kind of work together a little bit better, whatever we decide to do. Next, please. This is also the My Periopath. This is part of the same program. And they issue the results in 5 days. I think you're right, it's relatively expensive. And for some patients it may be important, and for some patients it may be less important. I would leave that up to you to decide, because that's your business. But I'm going to ask you to just help me for those patients who I gotta have help. Go ahead, Joni. And last slide on this is the collection process, and I'm sure you know how, this is, I think, not rocket science. And so when I asked them, could I do this, they defiantly said no. No doctor can do this. It must be done through a dentist's office. I said, okay, fine, I'll work with the dentist, but I can't do it. And maybe it's superfluous. You know, maybe you'll tell me that it's useless anyway, but it certainly did not sit well with me that the answer was just no. I don't do well with no. When it comes to candy or this, no is not a good answer. Next, please. So this is a new study that actually just came out, so I included this slide because literally it's in the literature this week. These are asymptomatic patients with an LDL less than 130 and an elevated CRPHS. And what they did is they said, okay, who's going to have disease and who isn't? And what they found, and I'll just consolidate this for you, this is the calcium risk score, and this is their risk of disease. What this study was trying to prove is that the coronary artery score was actually better than the CRPHS in predicting disease. And we have used CRPHS a lot. Now, the downside, CRPHS is a covered laboratory test. Coronary artery score is not a covered benefit in most cases. It costs about $125. It can be done down the street. I use it sometimes pictorially, so I say, hey, look, here's the disease, you know, and they actually send pictures to the patients. And in fact, just this week, I had a patient who told me that he stopped his Symcor. Symcor is a combination of simvastatin and niacin. He said he really just wasn't convinced that he needed it. He's about a 70-year-old gentleman who is the happiest man in the world. He used to work for French Airlines, and his wife and he are both retired, and they just travel and they love life. They're among the happiest people I've seen, and he's really a good patient. But he just didn't see the utility of taking his medicine. And so I said, well, that's fair. Let me just do a CAC score, and let's see if you need it. So I called him today to tell him that his CAC score was 187. Get back on that medicine. So he said, okay. But I had something that I could prove to him, because his question was legitimate. Because we've just talked about all those other things that are important. And his LDL was not that high. And his HDL was a little bit low, hence the reason for being on the combination of medicines. And he was a subclass B. But you know, 80% of heart attacks are in subclass B, but that doesn't mean that 80% of people with subclass B have a heart attack. So you can have small molecules and not have a heart attack. And so all these things are potential risk factors, but that doesn't mean a patient should spend $100 a month on medicines. And that's a pretty big chunk for, you know, especially for patients who are getting Social Security. You got to have a damn good reason. I think I had to get damn good reason. So he said, okie dokie, in his French accent, okay, Dr. Dwellings. And again, I was exploring your literature, and you can tell me that I'm full of it. So the Periostat is low-dose tetracycline. Do any of you use that? Doxycycline, which is tetracycline, yeah. I don't know if any of you use it. It has a lower risk of resistance, and adding an anti-inflammatory they showed would help, and it actually blocked the metaproteinases, which is, as I understand it, part of that inflammatory stuff that comes from those really bad, yucky bacteria that rest out in your mouth. Go ahead, next. This is this biofilm, and I really did sit and listen for 45 minutes. It was fascinating. So you got the good stuff and the bad stuff, and everybody has the good stuff, and you want to perpetuate the good stuff as a protective layer, and you want to make sure the bad stuff doesn't come along. So it's really kind of interesting. At least I thought it was interesting. And obviously we know, that when you clean that biofilm off, it's a huge source of endocarditis. That's a huge problem in our office, particularly if they have valves and stuff like that. So what I learned was that, this is a very well-articulated system, and that these pathogens really, they kind of find their place in this community of bacteria, and they all have their calling as to where they're going to settle in. And really it's the disruption of that bad biofilm that allows the good biofilm to be exposed and create, at least that's what I understood to be the case. Next. So the question is, how do I help my patients do that, and how do I help you do that? So in any event, this is saying basically the same thing, that there was an order that I had no idea about, and it was very complex and well organized, and they had wonderful pictures, and I'll show you this if you ever want to tell your patients what to do, because it was really a good site. So this is again about all that matrix, and go ahead, next slide. This is stuff that you know, and And the one that are at the deepest layers are, of course, dormant and very resistant to antibiotics, which is maybe the reason that we need higher doses of antibiotics over a longer period of time. But again, there's never been a study that showed that, ever. The key is this 1 year, 2 years? I think it probably is extended that far out. I think that we actually need to keep the gums healthy for a long enough period of time to give those markers an opportunity to go away. And I think that this will take, it's not a 6-month thing on my end, but it will take continued and persistence visiting on your end so that we keep going in the right direction. Obviously, we have to work together. I say MD and dentist together. There's no priority here. This is really a two-pronged process, and two professionals need to work together to evaluate the patient using drugs, lifestyle, good hygiene, and close follow-up. And clearly, that's the most difficult part, I think, is that follow-up. You know, they just, again, you know, they'd rather go out for dinner, and I don't blame them. Next, please. So anyway, that's what I had today, and I just think that if you can teach me what I need to do, and we can work better together, I am so sure that we can save lives. The thing about prevention is you never know whose life you saved, you know, who didn't get disease, proving the negative. But I think that it is my job to at least put that as a priority. And I may never be able to say, we were the ones that did it, but I'll be damned if I'm going to sit around and let it not happen, because I just think that's, you know, an abrogation of our professional duty. So, thank you very much.